This is a collaborative multidisciplinary medical case report of a rare idiopathic interstitial pneumonia designated pleuroparenchymal fibroelastosis, presenting with progressive dyspnea with recurrent pneumothoraces in an unexpectedly young patient and a pathologic distribution of disease that differs from current diagnostic criteria. On the right is our patient's timeline. A 34-year-old male presented with dyspnea, cough, and chest tightness. He was diagnosed with a pneumothorax and admitted for high-flow oxygen therapy. After discharge, he deteriorated clinically and was readmitted 6 times over a period of 13 months with recurrent pneumothoraces treated with pigtail catheter placement. During his 7th admission, he required mechanical thoracoscopic pleurodesis for refractory pneumothorax. Postoperatively, he became hypoxemic and was reintubated, ventilated, and eventually placed on veno-venous extracorporeal membrane oxygenation, VV ECMO. He ultimately underwent bilateral orthotopic sequential lung transplantation. On the left are representative sagittal slices from the CT chest scan, boxes B and D, right and left lung respectively. The CT scan showed upper lobe predominant pleuroparenchymal thickening, bilateral perilymphatic nodularity, bilateral lower lobe peribronchial nodules, and tracheal bronchomegaly. Further to the left are representative sagittal slices of the explanted lungs, boxes A and C, right and left lung respectively. Pathological assessment showed bilateral dense pleural fibrosis, subpleuroparenchymal fibroelastosis, and extension along fissure lines to encase central airways and pulmonary vasculature, predominantly in the upper lobes with notable lower lobe involvement. Of note, there are proposed radiographic and histopathologic criteria for the diagnosis of PPFE. However, upper lobe involvement with minimal lower lobe involvement is classically described. On the basis of clinical, radiologic, and pathologic evidence, a diagnosis of PPFE was made. PPFE can follow a rapidly progressive fulminant course, leading to respiratory failure. It is a progressive condition in 60% of patients and has a 5-year survival rate of 30%. At this time, lung transplantation is the only definitive therapeutic intervention. There are difficulties that can be encountered by the surgeon as a result of pleural fibrosis, specifically regarding the difficulty in finding an adequate tissue plane. This can create risk for postoperative bleeding, as well as thoracic nerve injuries, particularly for the phrenic nerve, which can be problematic for post-transplant recovery. Our patient, in particular, initially had poor lung function postoperatively. It has substantially improved in the subsequent year, reaching the 50% range compared to population reference values for both forced expiratory volume in 1 second, the green line, and forced vital capacity, the blue line. However, lung function remains subnormal at this new baseline dysfunction. We stress that it is important to recognize PPFE at an early stage, such that patients with evidence of progression may be evaluated for lung transplantation with no unnecessary delay, particularly in young individuals. Our case demonstrates the extension of characteristic changes of PPFE beyond the upper lobes should not exclude a diagnosis of PPFE. Thus, current diagnostic criteria, which state that lower lobe involvement precludes PPFE, should be revisited. Thank you.